So in today we are going to learn Horner's syndrome. Horner's syndrome, this is a neurological disorder which is caused by the disruption of the sympathetic nerve supply to the eye and the face. And as a result, you have a characteristic triad of ptosis, miosis, and anhidrosis. So ptosis, this is the dropping of the eyelid, and this is due to the paralysis of the superior tarsal muscle or the molars muscles. You can also have miosis, that is the small pupil or a constricted pupil, and this is due to the unopposed action of the parasympathetic, considering that you've already blocked the sympathetic supply. We can also have anhidrosis. This is loss of sweating, and this is due to the lack of sympathetic stimulation. So the pathophysiology of Horner syndrome, as I said, is a problem to the sympathetics. And the sympathetic that supplies or controls the face, the eyes and the face has three neurons, and damage at any point along this pathway will lead to Horner syndrome. So the three neuronal sympathetic pathway include the first order, that is the central neuron, and from the hypothalamus, which travels from the hypothalamus down to the brainstem to the spinal cord. So from the hypothalamus down to the brainstem to the spinal cord, and it reaches the CHCT2 ciliospinal center bulge. So any disruption in this center will lead to a Horner syndrome. And the causes include stroke, brainstem lesion, and multiple sclerosis. The second order, which is the preganglionic, this is after it has the pathways are the synpathetics have exited the spinal cord to travel along the lung axis and synapse in the superior cervical ganglion. So the causes that will lead to the damage of this pathway include Pancoast tumor, that is the lung cancer at the apex, and trauma or thoracic surgery. And the third, or the postganglionic, after they have moved from from the superior cervical ganglion and travel now into the blood vessels. So they travel into the internal carotid artery and pass through the cavernous sinus to reach the eye. And the causes of damage to this pathway are carotid artery dissection, which is the most common, cavernous sinus lesion, and when you have a patient who comes in with a cluster headaches. So the mnemonic behind this is just Horner's for H, which is the hypothalamus, which moves from the hypothalamus down to the brainstem, down to the spinal cord. And then O is out of the spinal cord, it goes to it is synapses in the superior cervical ganglion. And then R, where it rides on the carotid artery, that is the third order, and then nerve, where it reaches the eye. So this is just a repetition, causes of Horner syndrome, where he said we have first order, second order, and third order. So first order is the central, that is when causes is this when we have lesions in the brainstem and spinal cord damage. And examples include stroke, Waldenburg syndrome, multiple sclerosis, and tumors. Second order, this is preganglionic. This is we have said Pancoast tumor or chest pathology or trauma. And examples is just what I've said: Pancoast tumor, neck trauma, and thoracic surgery. The third order, that is the postganglionic. This is when you have head and neck vascular disorders. So this thing to do with the artery, because sympathetics go along with the vessels. So carotid artery dissection, cavernous sinus thrombosis, and cluster headache. So the most dangerous causes to rule out among the causes that we have mentioned here, all of obviously you have to rule out the causes, but these two are of note. That is Pancoast tumor, and this patient will come in being a smoker and presenting with cough and also presenting with Horner syndrome. In addition to that, carotid artery dissection. This patient will come in with neck swelling and also Horner, the triad of Horner syndrome, and this patient is at a higher risk of having stroke. Diagnosis, obvious diagnosis, our first diagnosis usually from history and examination. So a patient comes in with ptosis, patient comes in with meiosis, patient comes in with anhidrosis, and they have normal pupillary reflex. So in addition to that, you can also do clinical tests, and we have cocaine tests, and cocaine usually block the reuptake of norepinephrine in the normal pupil, and if it does that to lead to dilatation of the normal pupil, but not in Horner's syndrome. And this, the reason behind this is because already we have inhibition of sympathetic, so there's no release of norepinephrine. Aploconide test, this is an alpha agonist, usually dilates the Horner's pupil but does not dilate the normal pupil. Hydroxyamphetamine test usually help localize the third order neurons would dilate. So next we shall have imaging, and this is based on the suspected cause. We can have MRI or CT in brain if the honors is central, where you level a stroke, a MS, and a tumor. Chest X-ray or CT scan if it is past, if you suspect a pan-cause tumor. And how do you suspect? From the history, a patient comes in with chronic cough, and the patient is a smoker. In addition to that, CT angiography of the neck if you suspect a carotid dissection, and especially if the patient comes presenting with neck pain. So in treatment you focus on treating the underlying cause. So if it is stroke, you manage the risk factors, you give aspirin, thrombolysis if needed. If it's pan-cause tumor, chemotherapy, radiation, and surgery. If it's carotid artery dissection, anticoagulation, or antiplatelet treatment to prevent stroke. If it is cluster headaches, you give oxygen and triptans. So so this is a summary of the condition which usually causes ptosis, and we have owners which is said we have caused by ptosis, and pupil reaction is usually small because of meiosis and reacts normally to light. And key features is anhidrosis and slow dilatation in the dark. Oculomotor, which causes severe ptosis, and this one usually causes brown pupil, that is mydriasis, and this because of the inhibition of the parasympathetics and fixed to light. Whereas because it interrupts the extraocular supply of the muscles, we'll have eye down and eye out. Myasthenia gravis usually causes fluctuating ptosis. This is because the ptosis is worse in the evening, but the pupils are normally okay because we don't have disruption of the autonomic supply, and the ptosis usually worsens with fatigue and improves with rest. Botulism, this is ptosis and usually causes dilatation of the pupils. This is because of the inhibition of the parasympathetic, and you can have paralysis and dry mouth.